All right, good afternoon once again. My name is Dr. Chung, right? I'm one of the general surgeons working at Joshua Hospital. I'm the senior registrar on team 4. I think most people here know me. Um, so I think one of you guys program coordinator asked me to do this topic on the approach to abdominal pain. Now, I've done this topic before numerous times, but it would always be in the context of a surgical resident. So it was a little bit difficult to try to give you guys the scope that's required of a family medicine physician that sees patient in the outpatient setting that requires like a lot of extra effort because the differential diagnosis in itself can end up being so vast sometimes, right? This is, yeah, as you said, it's very wide. So I try my best to break it down into the process of coming up with an appropriate diagnosis after we've seen a patient with very non-specific complaints, all right? Just trying to zone in on those complaints and develop your differential diagnosis and then move on from there. Okay? About 5 to 10% of the complaints that all of us are going to receive is going to be from patients who have abdominal pain, right? It could be non-specific. And as a matter of fact, most of the patients that you see will have abdominal pains are not linked to a life-threatening pathology. Right? In the instance where you may see a patient that may not be in the best clinical condition, I would advise any one of you guys here to refer that patient to a hospital. Please remember, you're working in a clinic, you're not working in a hospital setting. All right? As we said before, the differentials are usually very, very broad. I would include differentials from any organ system within the area that the complaint originates from. And that's why, as I said before, it's important that we go through a systematic evaluation to be cost effective and to also be accurate at the same time. About 80% of your diagnosis will be made by the time you finish taking your history and physical examination. And that's why the history component is so important. Always remember your structured approach to asking about the pain. Everybody here remember from medical school, Olcarts or Socrates. And sometimes it might seem as though you're belaboring the point about the pain, but asking about the specific characteristic of this pain, the duration, the onset, these things really help you to zone in on a specific diagnosis. As a practicing surgeon for about 5 years now, rarely, if ever, I have a patient with a pathology that has coinciding complaints, exact complaints as another pathology. Very, very rarely, right? So when you zone in on these specific characteristics of these abdominal pain or this pain in general, it gives you a very narrow list to continue working with. The other thing is the associated symptoms. I know that when you're going through medical school, tell you, oh, well, do review system, and you're gonna ask somebody a lot of questions about eye pain, like how you gonna ask questions about eye pain as associated with abdominal pain, right? There is an association, but it's so far off that it probably won't even present in the practice, in your practice. Pay a lot of attention to the timing, right? The timing is important. The acuity, is this pain mild, moderate, or severe? Did the pain start first? Or did you start it to vomit first? Or did you start it to have fever first? These are things that help you differentiate. Early onset of severe pain is usually a bad sign. And there's a few things intra-abdominally that can cause these things, and they're all life-threatening. Perforated hollow viscous, ischemia to the bowel, an internal hernia, a patient with a ruptured appendix, right? These things usually have very severe pains associated with it. Insidious pains, you have a little bit more time to play around with, and they usually correlate more with an inflammatory or infectious process. A good example of that is somebody who may come with a diverticulitis. Those always have some insidious onset of pain, right? Persons can have mesenteric ischemia, right? But not complete blockage. And these patients may have more like a more insidious character to their pain. Understanding anatomy definitely helps. Knowing which organ originates in which particular quadrant would help you to focus on the diseases of that area. Not to say that pain can radiate, right? It can. But it's good to start there. It's very key to understand visceral versus somatic pain. Visceral pain is very dull. Very dull, very generalized, just because of the kind of pain fibers that innervates this particular area. Somatic pain is very, very specific, very pinpoint. A good example of that is a patient with appendicitis. When they have that visceral pain from the swelling of the appendix and the surrounding serosa, they have periumbilical, sometimes generalized right lower quadrant pain. But as soon as that parietal peritoneum becomes inflamed from the tip of the appendix or whichever part of it, you start get very pinpoint McBurney's pain, right? Innervation of the foregut, midgut, and hindgut is also important. The foregut starts from the mouth all the way down to the, anybody remember?
Second part of the duodenum.
Yeah, about the second part of the duodenum, right? And that would usually have epigastric pain. Umbilical pain is from the duodenum all the way to the sultora, the transverse colon, right? And then hindgut pain would be all the way to the anus, right? And that would be lower abdominal pain, right? This is just a table that illustrates to us what are some of the main or common diagnoses that can occur within a specific quadrant. Just to give you an example, right upper quadrant pain, you have biliary pathologies such as cholecystitis, cholelithiasis, hepatitis, hepatic abscess, and of course you can have referred pain from pneumonia or pulmonary embolus. Epigastric pain, very specific again, peptic ulcer disease or gastritis, pancreatitis. You can have some overlap with cholecystitis there. And then left lower quadrant pain, which is like a very uncommon complaint. You'd have something like sigmoid diverticulitis, which is a more common pathology. You can have genitourinary, lots of patients with kidney stones stuck somewhere, ovarian torsion in women, inguinal hernia. Anybody knows an occult hernia? So an occult hernia is the one that you cannot really, you cannot really see it on physical exam. You have to do imaging or some other form of investigation like imaging in order to determine that there's a hernia there, right? That's an occult hernia. A visual representation of what we were talking about. Just remember, I think that this is something that you have to commit to memory. You have to commit a diagram like this to memory, right? So that when you're dealing with the patient, doing your physical examination, in your mind, you're overlaying this image onto the patient's abdomen. You know where each organ lies. Specific characteristic of pain is very helpful, right? Very helpful. Dull, aching, stabbing, born in, you know. Colicky pains usually occur in small bowel pathology, right? And that's just as a fact of peristalsis. Every time they get a peristaltic wave, they get this colicky pain. Dull aching pain is usually due to inflammatory infections. And patients would tell you that the pain of appendicitis before it becomes localized is very dull. Likewise, the patients with diverticulitis, they would also have very dull pain, dull aching pain. Radiation, you must know which anatomical organs are radiating to one area or the other. And I have a diagram here. It is not by any extent exhaustive, but it's something that you can probably check on your own. It's in a textbook, it's online. Some of the more common ones that I commit to memory are exactly where the pancreas and the stomach pain radiates, where the liver pain or gallbladder pain radiates, where the appendix pain can radiate as well, right? Exacerbating, alleviating, and associated signs are important. One of the more important things that I find when I take a history is if a patient is still having pain that persists after they get pain medication, that's a serious pathology. That's a pathology that requires further immediate investigation, right? A patient can have a indolent pathology and you're giving them high levels of pain medication, diclofenac, cocodamol, tramadol, and they're still having breakthrough pains. That's something much more serious. Asking patients specific questions like, does the pain get worse when you eat? Do you feel better when you vomit? Do you feel better when you pass stool? Or do you feel worse when you pass stool? Those are things that can lead you in one direction or the other, right? You can start your review of system broad, but it must be consistent with the differential diagnosis. It must be. You can't ask a patient who's having diarrhea and vomiting if you're having any pains to the sole of your foot. That's absolutely out of the way, right? That's way out. It's just another another table showing you exactly which clinical features you can find associated with specific diagnosis. Everybody know appendicitis, right? There's the Alvarado scoring system. If you memorize the Alvarado scoring system, you know exactly all the signs and symptoms that you're looking for. Cholecystitis, usually patients have vomiting, nausea, they have fever. Small bowel obstruction, patient are passing stool, patient vomiting. Like, you look at those type of conglomerate of symptoms. And of course, not forgetting your past surgical history is also extremely important. You may ask a patient who has diabetes, malnourished, or who's immunocompromised due to many other diseases. These patients may not even mount a response, right? Those are things that you have to look for. Patients who are drinking, a young patient who drank alcohol all weekend comes with an epigastric pain to you in the morning. What does that tell you? What does that patient have? Yeah, that's the first common. A good second is gastritis, right? But the first thing on the list that can become really severe is pancreatitis, which is another thing I didn't really talk about. Your differentials, you should grade them, right? It should be the most serious differential that could kill the patient. And then you start listing all the other ones at the not so serious ones, right? Women always ask about gynecology history, I always ask about birth history, I always ask about contraceptive use, right? Patients who smoke, they tend to have like a lot of complications associated with smoking in any organ system. We move on to physical examination. The best advice I could give you is perform the same examination over and over. You don't get better at it over time. Make sure your examination is well rehearsed. And the thing about it is that medicine is like such a funny thing where you could spend 5 years in medical school and you will learn nothing. And then you can spend 3 years working and you could learn everything, right? It's more of an experience-based job. So it's important that every patient that you meet, you're able to learn something from it. And if you don't know, go home and read, right? Go home and read. Try to be better the next time. Omitting steps in the exam can lead to erroneous diagnosis, right? For example, a patient can come with right lower quadrant pain, and the patient can tell you, man, he got his pain for like 4 or 5 days now, it's hurting him really bad, it's dull. You think to yourself, oh, this could be like appendicitis, but you didn't do the DRE. Man probably got rectal cancer with meds. Those things happen, right? Because you omit the DRE, you didn't find the mass in the rectum, right? The patient's clinical condition needs to guide the tempo of your exam too. A man can be 80, 40 blood pressure, and 120 pulse, and you're like, alright, hold on, I forget my stethoscope, let me go to the car and collect it. I think come back patient, patient in worse condition, right? Patient looks sick, patient gotta go to the emergency, right? Don't waste time. You must know when, at least by this point in your career, you know when a patient look absolutely ill. Patient in shock, resuscitate whilst you're doing your examination. You must run concurrently. You can't wait until 40 minutes after the 2-liter bolus that you put up done, and you can say, all right, man, now it's good time to examine the patient, No, it doesn't work like that. You have to keep looking for a diagnosis. If patients are in severe pain, there's nothing stopping you from giving the patient some amount of treatment before you proceed with your examination. Anybody here ever tried to examine a patient who kicking and screaming for pain? Right? You can't do it. You don't get accurate findings either. This is just giving you some clinical considerations of specific things. Patient's hypotensive, sepsis, dehydration. Patient tachycardic, sepsis, volume depletion, or a heart attack, something cardiac. Patient tachypnic could be a compensatory response, right? Unstable patient, major things: GI bleeding, ruptured abdominal aortic aneurysm, a pulmonary embolus, perforated hollow viscous, or a ruptured ectopic pregnancy. You're looking at your abdomen. Is it rigid? Is it asymmetrical? Is the patient breathing, right, properly? You see rise and fall of the abdomen. Is it distended or scaphoid? Patients with severe amount of abdominal or high-grade abdominal, intestinal obstruction, you can see paracelsus through the skin, especially in a very thin patient. If a patient comes to you, a surgical scar, they're vomiting, not passing stool, what's the first thing come to your mind? Obstruction due to adhesion, right? Patient has ecchymosis around the back, the flank, right? You gotta think something like pancreatitis or ruptured ectopic pregnancy or a ruptured kidney or something. Patient has blood in the scrotum, same thing. The patient has hematoma to the scrotum, it's about the same thing. Abdominal extension, it could be medical, it could be surgical, but the rest of your examination is gonna dictate how that goes. Just an example. There's just an example of like Collins and Greater Emerson, right? And you can see some. You could. I mean, the reason I chose this picture specifically is because this is very mild. Like a clinician would look at this and be like, "And this man's seatbelt or something, or pants too tight, or some you would just dismiss this. But if you see a rash on a patient, especially at this level of care, you must take it into consideration. You must document it. You must look for something that may be causing it, right? It could be absolutely nothing, but it's better to investigate than to miss it. Auscultation is important, should be done in a stepwise manner. The IC valve is the most important place to auscultate. And don't forget to check for arterial bruit, such as aortic or renal, right? Palpation, we've done palpation millions of times. Start from the area away from where the patient tell you that they're having the most pain. How I do it, I ask the patient to cough. And tell them, after you finish coughing, point to the area where you're having the most amount of pain. They show me that area, I start away from the area and slowly work my way towards that area. Always remember to check for organomegaly. Rebound tenderness is something that is a debatable thing, but I still do it. If the patient is in severe pain, there's no need for you to do rebound tenderness. The patient has fulminant peritonitis, it's a surgical abdomen, right? Garden, like I said before, garden usually indicates fulminant peritonitis. Here's some other maneuvers that you could use to elicit peritonitis. So they got a cough test, as I said before. Inspiration tests, very good, very similar to Morphy sign. Put your hand in the abdomen, you ask them to inhale. If the inhalation process sticks, they have peritonitis. Right? There are other things that you do, like small children that you're not able to examine the abdomen. You ask them to go, you can either do what they call tap in the heel. You put your arm, you put your hand as a fist on the heel, and you tap it. If the patient having pains in the tummy, that's peritonitis. Alternative to this, ask the child to jump. Or just go up on the toes and drop on the heel. Alright? I know that we're still like a little bit of like traditional society. Sometimes it's hard for tell a patient, we got to do a rectal exam, or for tell a woman, we got to do a vaginal exam. But sometimes it leads to the diagnosis, right? It gives you extra clues that really, really help, right? You may be required to examine other organ systems, right? If you think that the patient has upper abdominal pain, it may be associated with a pneumonia, you'll have to check the chest. Lots of diseases have hand signs. They got a whole book. There's a whole textbook about hand signs, or what they call peripheral signs of diseases, of pathologies. Right? Now that you've finished your history and your physical examination, it's important that you move on to laboratory testing or imaging, which we'll do next. Most patients are to the baseline. I think you guys are already doing that. I mean, I don't think I need to tell you guys that. Women of childbearing age, everybody gets the HCG. Right? Everybody gets the HCG. The reason why I tell people to do the renal function test orally is because by the time you do your preliminary examination, you send patient for x-rays or ultrasound, and it comes back as something that may require further testing. You might gotta do a CT scan. You're gonna wait again another couple days to get back the renal function test? No. Do it at the same time to plan for the future. So you cut down the time in making your diagnosis, right? Other supporting lab tests that you can do include things like ABG. Anybody knows fecal calprotectin? It's not available in the public system, it's available privately. If you think a patient has inflammatory bowel disease, you can do fecal calprotectin, right? It won't be able to tell you which type of inflammatory bowel disease, but it will tell you that the patient has inflammatory bowel disease. The diamond patients that you think may have a clot somewhere or a thrombus. And most gynaes probably got H. pylori. I don't know why we didn't do a study on like the prevalence of H. pylori in the gynaes population, like large. Yeah, that's what that is, like a large amount of the population. It's all a pylori and egg ball we all eating from the road. try to get baseline imaging. Get your abdominal series. I think everybody here is familiar with abdominal series, right? Erect chest, supine, and erect abdomen, right? Always ask for the abdomen. Don't ask for just like a random abdominal x-ray. It's not really going to help. It's just like a one-time shot, and you're not giving you more information than it's not giving you sufficient information to get to any kind of diagnosis. How many people here guilty of ordering CT scans all the time? Me, I'm guilty. I'm very guilty of ordering CT scans all the time. You know what? Because it's available. I had a conversation with one of the more senior surgeons, right? One of my consultants recently. I said that, Doc, I find that ordering like a lot of CT scans, like I feel as though I'm doing too much. And then he said to me that don't worry about it. He said that is the way that medicine is going at the current time. Especially in the developed world, almost everybody now with any type of complaint eventually gets a CT scan. If you're uncertain and you think this patient has something serious that's going to affect them, it's going to cause them to be debilitated, miss work, probably lead to death, do the CT scan, right? Of course, there are other investigations that you may order. A patient with peptic ulcer disease or a patient with diverticular disease may require a scope at some point or the other, right? Here's a table that has diagnostic imaging consideration based on diagnosis. You can see the sensitivity and specificity. By no means is an exhaustive table, but it can be helpful, right? These are just some signs that you can look for on plain radiograph. Pneumoperitoneum, air under the diaphragm, perforated hollow viscous. Air fluid levels, small bowel obstruction. Double bubble sign, malrotation of the midgut. Sentinel loop, pancreatitis. Right? Coffee bean sign, sigmoid volvulus. And these are very common things that you should remember. Now, before we go into the case discussion, you guys have any questions? Anything you're unclear about? Something that you may have read that you're not certain about? Huh?
Doctor, I want to ask a question. So I recently came across a patient. I didn't see the patient personally, but they had an abdominal ultrasound that was shared with me, and it was diagnosed with Chilaiditi sign, where the
Chilaiditi sign?
Yes, where the intestine intercourse between the diaphragm. I don't have any experience with that. In terms of management, what's the best approach to that management?
So, Chilaiditi sign is supposed to mean that there's nothing really serious going on there. It's just a piece of bowel that is interposed between the liver and the diaphragm, or even the spleen and the diaphragm, right? For me, my question is, why is the patient's bowel so distended that it gets up there, right? Because Chilaiditi sign basically means that the patient doesn't have pneumoperitoneum. It's just a bit of bowel with some air up there. Now, in a patient like that has enough air in their bowel to go up that way, first I would ask, is the patient young or old?
Oh, around 50 to 60.
Good. So that patient needs to be further investigated for signs of either colon cancer, chronic constipation, partial volvulus of the sigmoid, because those pathologies fit more within his age description. Older patients more likely to get colon cancer, and colon cancer starts without full obstruction of the colon. It starts with only partial obstruction of the lumen. Agree? A patient may have a very redundant sigmoid that can become partially twisted, right? A patient may have diverticular disease or chronic constipation that may affect them from passing stool, right? What was the other complaints that the patient had that he come to clinic with?
I was only told patients having discomfort, abdominal discomfort.
Just abdominal
Yeah,
discomfort.
I didn't find out more details.
So maybe that's the direction that you need to take the history and the physical examination. Alright? Anybody else? Any more questions?
Just one thing, like, well, it's more with appendicitis when it comes to kids using the alcohol to score,
Mm.
you know, when to I can say set, when I can, you know, continue. Well, always do the labs and then because in our settings, at least my health center, we don't have labs. So part of the alcohol score, part of that.
I'm not sure you could say that on video, but that's okay.
Looks like it's a protocol, so.
Yeah, here's one. I would say to anybody. When I finished residency in 2020, appendicitis was an absolute clinical diagnosis. If you feel the patient has appendicitis, you're not able to get labs, do you have access to ultrasound?
We had point of care, but point of care for kids
It's pretty tough.
it's pretty tough. Honestly.
It's pretty tough.
These cases I would generally, especially when it's severe pain, give them the fluids, give them the observation, and no improvement, I would always send them to.
You know what's the difficulty with that particular scenario? Is knowing what's the cause of appendicitis in children. The normal pathologic process or the pathophysiologic process is the lymph node becomes swollen because of some other infection that the patient may have. Now, the bad thing about it is that lymphadenitis or mesenteric lymphadenitis would cause the same type of pain as you get with appendicitis. So it is pretty difficult.
Yeah, that's
Or maybe such an early appendicitis that even if you do some form of imaging, you might not be able to pick up the appendix at that point. In those cases, I think if you're not able to get labs, you're not able to get an ultrasound, the safest thing is to refer the patient to an institute who can have it. But if you don't have the ability to refer to a place or a hospital that can do definitively diagnose the patient, have close follow-up. Let the patient take some antibiotics. After you've given them some fluid, antibiotics, pain medication, and you bring them back tomorrow morning, or you bring them back tomorrow afternoon, and check them. A lot of children who have appendicitis now can be managed conservatively with antibiotics, fluids, bowel rest alone. So in essence, you would still be treating the appendicitis, right? You would still be treating the appendicitis. That's a very tricky scenario. It's very tricky.
because there was also a question between we're taking appendicitis, giving antibiotics or not giving antibiotics. Because I was once when I was in the hinterland and I had a child taking appendicitis. Working on the Cubans, they would say, give antibiotics. But when I called, emergency at Georgia, one of the emergency doctors, I just said, why do you give the antibiotics at that time? That's something I still continue to read up to check and see.
I would advise anyone here, if you've made a diagnosis of appendicitis and the patient is being transferred, please give the patient antibiotics before the transfer, right? So the antibiotic, you stop the progression or you slow the progression of the appendicitis whilst the patient is being transferred. If they send you to Timbuktu, bro, and you gotta transfer patient out, you're thinking appendicitis, you think any infectious or inflammatory process, start your antibiotics whilst you're waiting for the patient to be transferred. Okay, it's safer. The only wrong thing with that is that antibiotic advocates will tell you that, oh, you're causing some amount of resistance, right? You can't cause resistance if the patient die, right?
Yeah.
Anybody else? No? Alright. How much people in the final year here? Show of hands. To me, like, you there wrong long ago, like.
Oh God.
It's joke, but then, I mean, if it'll be embarrassing. So you got a 24-year-old male patient comes with epigastric pain, vomiting starting 2 days ago. The pains are constant, vomiting are multiple episodes, large volume. What are the things you'd like to know about the patient?
Characteristics of the vomit, is it violence, vomit?
No. It's just like
Fever.
greenish vomit. No, you can get no fever.
His travel history would be of importance to me because we are endemic region.
No, you didn't travel no way.
I would want to know what else of his history. His past medical history also is important.
He has no past medical history, he has no chronic illnesses. He works as a construction worker.
Alcohol consumption with this patient is.
Yeah, he just drink every weekend.
Okay. Vitals of course.
He's stable at this point. He come see you at your private practice in Prattville.
Epigastric pains only.
Yeah, when you examine him, you just get some no radiation.
Okay, of course you want to get all the characteristics of the pain, so you go through your whole
He said the pain is dull, non-radiating. When he sits forward a little bit, the pain eases. Right when he lie down, the pain is worse. When he take 2 Panadol, he said the pain go away a little bit, but then it come back. And yeah, when he lie down, the pain gets worse. That's about it. He could tell you about the pain.
Okay.
It's about 4 out of 10.
Okay, intense. So these are young. His vitals are stable. He's having pains. I want to do some more investigations.
But what are your top differentials?
He has a significant alcohol history, drinking every weekend. We gotta make sure nothing's wrong with his pancreas, pancreatitis. He said no fever.
No fever.
No fever. He could have ulcerative gastritis.
Correct. He could have a gastritis or peptic ulcer disease. Could also have H. pylori infection, right? Right. Because you eat in the egg ball and the pylori when you drink, right? So how you would make this diagnosis? So now you get your top 3. What's your very next step? What you would order next?
I want some walks with him, something like that.
Yeah, other than baseline, is there anything specific? You do your alright, let me be clear. You do your CBC, renal function, serum electrolyte. Is there anything else you want?
Amylase.
Alright, very good. So you do your amylase, comes back as 1,000.
Yeah, sending it to you.
That's correct.
But yeah.
Alright? You got a 56-year-old female patient, comes with a 4-day history of right upper quadrant pains, 1 episode of vomiting, and jaundice. She refers loss of appetite. What are the things you want to know?
Past medical history.
She's 56, she's diabetic. Never had surgery done before.
Medication, she any medication.
Metformin.
What social history? Drink?
No. She's just a housewife. She home all day.
So I would want to know if she does any farming.
No. She's just a
No farming.
just a housewife.
And
Yeah.
I would also take a gynecological history, OBGYN.
Okay, so she's in menopause. She don't see her periods anymore. She used to use an IUD for contraception. She was pregnant about 7 times, but she only delivered 4 times. When she used to get her period, it was regular. Menarche at 12 years old.
In addition to the symptoms she has up there, anything else? Any fever?
She does have very low grade fever that occurs in the afternoon alone.
Alright, so the next question? Differentials or?
No, well, the
Still
physical
asking.
examination,
Yeah.
she just has tenderness to the right upper quadrant. You could just feel the liver just a little bit enlarged, like barely under the costal margin. Right? You look at she's clearly very ecteric, but it's not dry or anything of the sort, right? No other physical findings in the abdomen. Oh, when you do the DRE, the stool had a little bit of like, it had like a gray color to it. So what's your top differentials?
Cholecystitis.
Mm-hmm.
Is very important. Probably colitis, cholecystitis. I would want you to share a little bit of fever, so I would be concerned about something like cholangitis.
Yeah.
Right? As well as the other ones, the colodoco.
Yeah, stone in the common bile duct, right? A stone. And a matter of fact, the stone in the common bile duct should be the top differential, right? 56-year-old woman, many pregnancies before, right? I mean, probably should ask the BMI, or I probably should have given you the BMI. The patient is mildly overweight, so those are all the descriptive factors for somebody developing gallstones, right? And you'd make your diagnosis how? What you'd order?
Sarcoma ultrasound.
You do your baseline labs, LFTs and so included, and then the ultrasound for sure. I agree with you. I don't disagree with you, but the ultrasound for sure will tell you if there's a stone there or the dilation in the duct. Right. Last case. Who was the last person in the final year? Nobody else?
The four of us. 1, 2, 3.
Oh, okay. All right. So you have a 22-year-old male patient comes with a history of central abdominal pains for 2 years, fluctuation of weight, episodes of diarrhea and vomiting intermittently. Refers that he fed up with these symptoms, and now we come to see a doctor for the first time concerning it. What are the things you want to know?
Okay, so more about the pain firstly. It said wasn't going anywhere else.
It's usually a dull, generalized abdominal pain, no radiation. Sometimes he find that when he pass stool, the pain would act up just a little bit, but it don't happen very often. Not a couple of Panadols alleviate the pain for a little bit, but sometimes the pain just goes away, and for months he wouldn't have the pain, and then the pain would come back again.
And when the pain comes back, any fever, any associated aggression, vomiting?
No fever, just sometimes you get the diarrhea and vomiting when the pain comes back.
Okay, so those are only with the pain.
Yeah.
Fluctuations in weight, as in weight loss or weight gain?
Sometimes he would lose weight and then he would gain it back, and then as soon as he get back the pains again, he would lose back some weight. And then in between the pain episodes, he would gain back a little bit of weight.
Any other illness he suffers from?
No, I think it was
Any other significant other history past?
no allergic history. No, he doesn't. He has his little bit of alcohol every so often, doesn't smoke. He works in an office as an accountant.
And it's always central, no time like whatsoever.
It's not more central, it's more like generalized. Almost it starts from the center, but then it becomes a little bit generalized.
Anything makes the pain better?
A couple of Panadol, but then the pain will just.
On physical, any positive?
At this point, he doesn't have the pain. The last time he had the pain is probably about 3 weeks ago. But he's so fed up with the whole issue and losing a little bit of weight now that it just comes to you.
Tough different goals. So I'm thinking it's something chronic because it's been 2 years.
Very good.
So that would take out like appendicitis and all.
Yeah, no, definitely.
Probably like a diverticulitis, but then you said it's not really on the
Well,
side.
think about it. This is a type of pain that's done. So it's either inflammatory or infectious. It occurs ever so often. I don't know of an infectious process that occurs every couple of months for like 2 years. So it has to be inflammatory. And then the patient loses weight when he goes through this. Correct. So it's more in line with inflammatory bowel disease. Remember, you don't lose weight with diverticular disease, right? Because if you could have done it, then all we would have hoped for get diverticular disease and lose some weight. But it doesn't cause you to lose weight, right? So you'd make a diagnosis now.
Well, as a definitive diagnosis, you see. I know you could do like endoscopy before not. I don't.
You can order if he has a flare up, or just a little after flare up, you can do an endoscopy with biopsies. You can also order your fecal calprotectin. You mightn't know exactly which one, but it would still help you to make the diagnosis of inflammatory bowel disease. Likewise, you could do all your right. Sorry, what did you? Well, good. You could do your immunological markers, right? Like your Pianca and these different type of things, right? I don't remember a lot of these things in detail, but. Right. So it might point you in one direction. Sometimes it comes back equivocal. So this inflammatory bowel disease thing is very difficult to diagnose, right? Very difficult to diagnose. All right. And that brings me to the end of the presentation. Thank you.